So we're talking about the hematologic system, and what we know about the hematologic system is that we're producing blood, and the other things that we produce besides blood are the types of cells. So if you look at this picture, the red blood cells are the erythrocytes, and then the white blood cells are the leukocytes. Specifically, these are the granulocytes, so the basophils, the eosinophils, and the neutrophils are all, when you stain them, they show up with granules. Over here, the ones without granules are lymphocytes and monocytes. So both together are known as leukocytes for all five of these. And then thrombocytes we know as platelets. Okay, so the importance of this then is anything that's going to disrupt any of these types of cells are going to cause the different conditions that we're going to talk about here. So there's two components of blood. There's the fluid part and there's the cellular part. And the formed element specifically is the parts are made of red blood cells, white blood cells, and thrombocytes, which we just talked about. And these obviously are important because we need these. We need them specifically for cellular metabolism, defense against microorganisms, and for acid-base balance. The formation of blood cells, as we saw, occurs in the red bone marrow. So anything that's going to disrupt the red bone marrow is going to affect the red blood cells and the white blood cells. And this is done specifically by a hormone known as erythropoietin. And there's feedback mechanisms that are going to try to maintain an ideal number of cells. If we don't have enough red blood cells or white blood cells or platelets, then we wind up with some of the diseases that we're talking about today. And obviously they're integrated with the lymphatic system and the immune system. The signs and symptoms then of a hematologic disorder is going to be the following. We're going to talk about some of these. Okay. So edema and congestion. In this picture, we're showing you a picture of someone checking for pitting edema. And this is just, again, as we mentioned before, you're pressing in the lower part of the extremities, or you could do it in the upper extremities also. But we're looking for excessive fluid within the interstitial tissues. Congestion is the accumulation of excessive blood within the blood vessels of an organ or a tissue. And so this is an actual picture. If they were just to orient you, this is the posterior aspect, so this is the vertebrae, and this is where the lungs are, and then this is the heart. Okay. And specifically what it's showing you, it's not showing you most of the heart, it's showing you a part of it, but it's showing you a blockage occurring, and specifically a pulmonary embolism, and this is a CT picture, computed tomography. Infarction, as we know, is an area of necrosis. So back to the picture of the heart, then if we talk about the heart, we talked about the left ventricle in a situation where if we had a heart attack or an infarction, then oftentimes then that heart is not the same afterwards. And so if we're not getting oxygen to all of the muscle layer here of the left ventricle, for example, then that may cause ischemia to occur, and if we're not getting oxygen and we have myocardial ischemia, we're more likely to lead to an infarction or a heart attack. Thrombus or embolus, this is a picture showing you a thrombus, specifically deep vein thrombosis that's extending up into the popliteal area. So if you think of this as being the vein below in the calf, and then this brownish thing right here is protruding out of the vein. And the problem with this is if it gets dislodged, then it leads to an embolus, and that embolus then for this one is a pulmonary embolus, and this has a specific name known as a saddle embolism, in which it's occluding two areas, which is not good, and it's not conducive to life. The importance of these then are, as we've said previously, or talked about previously, is that these are more likely to occur in lower extremity surgeries, and that's what part of our bread and butter is getting patients up that have had lower extremity surgeries, like a total knee or a total hip. And the problem is one of these deep venous thrombosis then dislodges and goes up into the lungs and kills the person. We can have solid, such as this one. We could also have a liquid or a fat emboli and or a air emboli. And so that's also possible. Even this is chronic swelling of an area and disorder of the obstruction of the lymph, which we've already mentioned, the lymph channels and the anchoring filaments that occur with lymph channels to open up the lymph channels. But now we're talking about an obstruction of the area. And you can see in this picture, this is a picture showing you the lower extremities, And the problem down here is that this lymphedema then is setting that person up for possible wounds. So lymphedema kind of sets up the stage for other things to happen. Bleeding and bruising we know as ecchymosis, and usually occurs from a trauma occurring. It could be a minor trauma. And two things to know about for bleeding and bruising or ecchymosis would be purpura and petechiae. So purpura is when we don't have enough platelets that are available to plug the damaged vessels and prevent leakage from injury. Characterized by the movement of blood into the surrounding tissue under the skin. So this is showing a foot, and these red spots here are purpura. And then petechiae are small red patches that appear on the skin, and they are broken red blood vessels. And oftentimes we see these occurring on the trunk of an individual that has heart problems. A shock is a condition where the circulation, the blood, is not moving around as it should. And so if it's not moving around as it should, it doesn't perfuse the organs. So the body reacts clinically then by increasing the heart rate and increasing the breath. When we look at that person on examination, they find that their extremities are cold, they don't have a good pulse. If you look at if they were able to, they would have a decreased urine output, an altered mental status, very much like the 100-yard or 50-yard stare, and obviously low blood pressure that initially may be absent at first because they're in a state of shock, but then hypotension. If it's a shock that continues, then they have low blood pressure. End result of shock, obviously, is not getting enough oxygen to the kidneys, the brain, the heart, any of the tissues, or any of the organs specifically. And of course, the things that could cause shock would be sepsis. So sepsis would be a situation in which there was, for example, one of the ones I saw was in the operating room was a person's stomach. Due to a trauma, this person's stomach was lacerated, and so the contents of the stomach were spilling out into the abdominal cavity, and that obviously is not good. Liver failure is another example. Severe pancreatitis, anaphylaxis we mentioned for bee stings is a possible thing for anaphylactic shock, and thyroid toxicosis we'll talk about is a thyroid storm. The three most common types of shock then are heart shock, cardiogenic, hypovolemic state, and then anything that's going to reduce the systemic vascular resistance. Okay. Red blood cells are needed. There's a picture showing you the biconcave structure. It looks very much like donuts, right? The red bone marrow derived, as we saw in the first slide, and it's controlled by the hormone erythropoietin. The half-life of red blood cells is about 120 days. And after the red blood cells are no longer functional, then they go to the spleen. And so we may have situations where if there's a red blood cell problem, we would tend to see splenomegaly or an enlarged spleen. Okay, and so sickle cell anemia is an example of a situation where there might be splenomegaly. The function of red blood cells are to carry hemoglobin and transport oxygen and CO2, and then they also act to control or modify the pH. Possible contraindications for exercise when we look at the red blood cells is we will have hemoglobin and hematocrit. So these are two terms you probably heard before, but maybe wasn't understanding specifically. Hemoglobin is the number of red blood cells available, and hematocrit is the percentage of the red blood cells or the formed elements in the fluid. So why is this important? Because there's levels that specific hospitals will look at, and it helps us to decide if we're going to do exercise or activities for an individual. So oftentimes hospitals have their own reference values that they use to decide if they are going to exercise someone or not. But these are useful because sometimes you'll have healthcare professionals that don't know these or not aware of these and ask you to do an activity like, for example, go get the patient up in 202 and take them for a walk or do some form of exercise with them. And these references are things that we need to use. For males, this is the level, and for females, this is the reference level. And if we get below 10, then we have a reduced exercise capacity for hemoglobin. exercise 8 to 10, and we are not supposed to perform activity below a level of 8 for hemoglobin. For hematocrit, the percentage of red blood cells in the blood, these are the ranges for males and females, and then reduced exercise capacity occurs at this, markedly reduced exercise 24 to 30, and we're not supposed to perform activity below 24. So these are very useful slides clinically, especially this one, because they're evidence to stop us from exercising people, because we're going to do more harm than good if we get these people up, and they are probably receiving transfusions. Hemochromatosis is a recessive hereditary disorder, and it's characterized by too much iron absorption by the small intestine. We tend to see it in these individuals. It's more common in males and females, and what we wind up with is weakness, chronic fatigue, elevated hemoglobins, hepatomegaly, and elevated liver enzymes, along with some joint and abdominal pain. Anemia is an important one for red blood cells, and again, we've talked about this decreased ability of the oxygen carrying capacity of the blood, specifically the red blood cells. I want you to think of it as a symptom, not specifically as a disease. There's a number of things that cause it to occur, but it's a symptom of the different things that cause it. So we're going to talk about those. So diet, specifically B12, if there's not enough B12, then that tends to lead to anemia. So the background on this is the parietal cells in the stomach make intrinsic factor. Intrinsic factor is needed for B12 absorption. So if there's a problem with the stomach and or a problem with the creation of intrinsic factor, then that's going to affect our ability to have B12 in our diet. Acute or chronic blood loss, obviously acute would be a trauma situation. Chronic blood loss might be a situation such as a GI bleed in a patient that has had pain for so long and they're taking too many non-steroidal anti-inflammatories, leading to chronic blood loss. Congenital defects, the most common one is the sickle cell anemia, which winds up causing that donut-shaped red blood cell to form much like a sickle, and because of that, then it's not able to transport oxygen and CO2, get the CO2. So we wind up again with a case where the spleen might be completely packed full of these non-effective or defective, so to speak, red blood cells. Exposure to industrial poisons, bone marrow disease, obviously, because bone marrow is producing red blood cells, and then chronic inflammatory infectious, or we'll mention neoplastic diseases. And we're going to talk specifically about these. I believe it's in the next slide. Yep. And classifications of anemia, then, acute or chronic blood loss, things like hemorrhage, excessive menstruation, hemorrhoids, peptic ulcer, or renal failure, things like hemodialysis here, would cause acute or chronic blood loss. Destruction of red blood cells, if someone runs too much, they might wind up with the lack of red blood cells available, or red blood cells that are not effective, and so it's known as runner's anemia. I thought that was interesting in the book, they mentioned that. And then decreased red blood cells due to nutrition. So again, iron, B12, and folic acid is needed. Molecular defects in the proteins, here's a few of them. The most common, again, is the sickle cell anemia. Endocrine disease, we'll talk about the endocrine system coming up. Hypothyroidism is one of the conditions that might cause anemia to occur. Leukemia, we'll talk about that in this lecture. Aplastic anemia, chronic inflammatory disease, end-stage renal disease may also lead to less red blood cells. Anemia is common to therapy, specifically would be, as I mentioned, the NSAID use. We treat lots of patients with chronic diseases such as RA or SLE, and you're probably tired of hearing about those. Folic acid conditions or alcoholism, we treat individuals that are unfortunately, alcoholism. Infectious disease such as AIDS, and then specifically for oncology would be bone marrow transplants, or things that we'll talk about towards the end of this lecture. So anemia pathogenesis would be if you have an excessive blood loss, usually seen in trauma, increased destruction of red blood cells, so conditions that might cause destruction of the red blood cells like sickle cell anemia, and then decreased production of red blood cells. Okay. Hemoglobin specifically requires iron, vitamin B12, and folate. And so it's needed for iron specifically is needed for DNA synthesis, oxygen transport, and respiration. And the blood loss causes iron deficiency because these red blood cells are the site for iron storage. So any change in iron storage, such that occurs in menstruating women, growing children, someone with a lower socioeconomic status would be less likely to have iron in their diet, and/or older adults might affect their ability to produce hemoglobin, right? Vitamin B12 is needed for DNA synthesis also, very much like iron. If we have a diet that's deficient, most often due to absence of intrinsic factors, what I gave as an example. And the example here would be pernicious anemia. And so in pernicious anemia, the problem is related to intrinsic factor. So PA is pernicious anemia. And then folate oftentimes is one of the things for pregnant women and what they take during their trimester is folate is needed and again for hemoglobin production. So if there's an inadequate diet intake of folate, alcoholism, anorexia, malabsorption syndromes, large amount of overcooked foods, then that will affect the hemoglobin production specifically due to these things affect folate. And so folate for pregnant women, they need 6 times the normal amount for developing babies. So oftentimes they're given as prenatal vitamins and maybe as a supplement. The signs and symptoms of anemia then, skin pallor. The pallor is a white, very bright white, dull white color that, when someone looks like they turned or saw a ghost turned white, that's the same idea of skin pallor. Also may see yellowing of the palm of the hands. The nail beds specifically might turn yellow and/or loss of color. Fatigue and listlessness, obviously, because they're not getting the red blood cells and the oxygen to the tissues that they need it. DOE is dyspnea on exertion, so when they exert themselves in a normal activity, they wind up with palpitations and rapid pulse because of that. Increased angina, so chest pain in individuals that have pre-existing coronary artery disease. Leg ulcers, they're more common with patients with sickle cell anemia. And colonectia would be, if you look at figure 14-1, it's showing you specifically the fingernails of an individual. So please check that one out. And then the other sign would be symmetric sensory neuropathies in the lower extremity. So in these individuals, they have decreased sensory nerves in their lower extremities. And then positive Romberg sign. I'm not sure if you've learned Romberg sign yet, but if you stand the person up with their feet together, eyes closed, and arms crossed across their chest, they tend to lose their balance because they have anemia. So that anemia can play a factor in affecting the Romberg sign. Again, big picture wise, important for this is showing you that all these, from the bone marrow, all, pardon me, all of these different cells are produced. Interesting with this has everything to do with the bone marrow, and this is related to stem cell research. And so if we were to take the cells here, like the progranulocytes, take them out of the spot that they're at and move them to the megakaryocytes, because they're around the types of cells that they are, and then they will change their function. So if we were to take one type of cell, we could produce another type of cell if we were just brought them close together, which I think is extremely interesting related to stem cell research. Leukemia is when the white blood cell undergoes a neoplastic transformation. What I want you to think of as leukemias are malignant, and there's an acute and chronic form. The two forms are myelogenous and lymphoblastic. So myelogenous would be within the bone marrow, and then lymphoblastic would be produced from the lymphocytes. So these two forms are for acute. In individuals over 70 years of old, they have a 12-fold increase in getting acute leukemia. And specifically, the acute affects the granulocytes, the monocytes, the red blood cells, and the platelets. The chronic, there's two forms, the myeloid, so it changes the name, and lymphocytic. So lymphoblastic are the lymphoblasts turn into lymphocytes, and the chronic, it affects the next set of cells. And so in chronic, they live without knowing they have it. They usually have a very poor prognosis. Once they're in the malignant stage, the survival is measured in months, and it's quite aggressive. If you've seen this, it's very difficult to deal with. When we're looking at this big picture-wise, if we have pathogenesis of leukemia, if we have excessive white blood cell precursor growth, then that's going to cause metastasis to occur because the white blood cells are different and there's too many of them. Might have local bone invasion of the neoblast, and that would lead to pain, obviously. We could have a disruption of the normal marrow function, and that might lead to a situation of not enough neutrophils. That might lead to a situation of not enough red blood cells, and that might lead to a situation of not enough platelets, thrombocytopenia. And those things then might, because of neutrophils, the white blood cells, we might lead to infections. The anemias might lead to, the impaired hemostasis, or the ability to stop the blood if we have an inflammatory process, would lead to increased bleeding, and the increased bleeding would lead back to anemia. If we have the spreading of this condition, we have the spleen that enlarges, and we also have hepatomegaly occurring and other systemic effects. So that's the big picture of leukemia. Again, this is the visual of what we were talking about in the previous, what was it, 2 slides ago. It was leukemia, the acute and the chronic. With the acute, it's an abrupt onset, more severe symptoms, immature cell forms, so that's the blasts, right? And then the chronic would be a gradual onset, less severe symptoms, and these are already differentiated cell forms. So these are the different types of chronic. Acute signs and symptoms: abnormal bleeding, easy bruising in the skin, excessive or abnormal nosebleeds, epistasis, hematuria is blood in the urine, and rectal bleeding and or infections. The chronic, fatigue, dyspnea, weight loss, loss of appetite, fever and sweats, pain in the lower abdominal region, specifically in the left lower abdominal, if I remember correctly, and occasionally epistasis, so not as many nosebleeds as what someone would get with acute form, and then easily bruised, as we mentioned at the beginning of this lecture. Multiple myeloma is another condition. It's a rare condition. It usually affects 50 to 70-year-olds, and it's specific to the thrombocyte, right, the plasma cell. So it's a neoplasm change, abnormal plasma cell. The hallmark for this is lytic lesions. So the pathognomonic is lytic lesions. And so what we wind up seeing is a situation in which areas of the bone, because we know the bone, specifically the red bone marrow, makes the red blood cells, and we talked previously that the flat bone, specifically the skull and or the pelvis, produces these red blood cells. And so what winds up happening is we have disruption to that area. And so not only does the bone marrow produce the red blood cells, it also produces the platelets, which we saw in the first slide. And so because these platelets are disrupted, what winds up happening is the neoplasm itself will digest the bone. And so, for example, in the flat bones, the skull tends to look like Swiss cheese. And so if that's occurring in which someone had an x-ray in which you saw sort of patchiness or abnormal growth of bone, it has to do with the multiple myeloma causing that to occur. And so oftentimes we have a case where we have pathological fracture. So pathological fracture would be a situation where someone's just doing a normal activity and all of a sudden fractures their femur, fractures their humerus, lifting something really small. And that's what a pathological fracture, and that occurs commonly in multiple myeloma. Signs and symptoms then would be skeletal bone pain, and oftentimes in the thorax. A lot more movements occurring in the thorax, and these are small bones, looking at the ribs and things like that. They wind up with recurrent bacterial bacterial infections, fractures. They will wind up with anemia, and because of anemia, they wind up with weakness and fatigue, and then also a lot of urine or polyuria, loss of appetite, and vomiting. The least significant, however, is often seen is carpal tunnel syndrome. Lymphomas is a neoplasm of lymphoid cells that spreads in the lymph nodes and then spreads to the blood, and this is specifically then known as leukemic conversion. And so the leukemic conversion has to do with non-Hodgkin's lymphoma and Hodgkin's lymphoma. The non-Hodgkin's lymphoma would be the signs and symptoms of it would be enlarged lymph nodes, fever, night sweats, weight loss, bleeding, infection, red skin, generalized itching of unknown etiology. That's non-Hodgkin's, and so that is a situation where the leukemic conversion is present. Then Hodgkin's lymphoma signs and symptoms is painless, the progressive enlargement of the unilateral lymph nodes occurs often in the neck, that they have these progressive enlargements on one side of their body lymph nodes. In a C-spine exam, we might notice that. Okay, so as we're checking their range of motion, we might notice on palpation they have these large nodes. Okay. Other possible signs and symptoms: fatigue, fever, night sweats again, anorexia and weight loss, and in this situation there's severe itching or, as we talked about, pruritus over the entire body. Polycythemia would be a condition that occurs at the bone marrow where there's too many red blood cells that are present. There's two types of primary and secondary, and this is very much like the hypertension that we saw when the primary knowing about it or not knowing what causes it, and secondary knowing actually what causes it. So the primary is the more common, and occurs at 50 to 60 years of age, and the secondary is related to a decreased oxygen supply to tissues and an increased amount of erythropoietin release. So remember, the hormone that produces the red blood cells is, if we have too much of that present, then that will lead to too many red blood cells, and that too would cause a congestion in an area, because too many red blood cells would increase the viscosity of the blood, so the blood would not move as well. So what does that do? As we just said, related to hyperviscosity or thickness, it also would cause an increased volume, and it will also cause an increased metabolism rate to occur. So these individuals specifically will have all of these different conditions, and I outlined a couple of them. Let me make sure I've covered everything. Yep. So intolerable pruritus is one of them. So again, excessive itching and clubbing of the fingers. So clubbing of the fingers specifically, then, if you were to look at this nail, no, that's not a normal nail, and this is a clubbing that occurs. Okay, so at the very end, almost looks like a hammer. This is a fingernail. And from the top view and from the side view, then this is what clubbing looks like of the fingers. Okay, why is that? Well, if there is an altered red blood cell, or especially as we get to the respiratory lecture, if there's some kind of situation in which oxygen exchange is not occurring, then oftentimes we can look at the fingernails and figure that out. So we're going to see this reoccur in a couple of different things, and the different types of nails. We're going to need to spend a little bit of time talking about nails as we get back to face again. And then a backache is the other thing. So thrombocytopenia would be that, we're talking about the ability for blood clotting to occur, thrombocytes, right? So adherence and aggregation then is going to be affected. And so you go back to the first lecture talking about inflammation and the cells that are going to form a blood clot, and the adherence, the stickiness, and the togetherness of the ability of the platelets to be in the area is then going to be affected. So this is caused by penia, being inadequate number of platelets available from the bone marrow. So the bone marrow is either disruptive, or the platelets are disrupted or destroyed outside of the bone marrow. So again, makes sense. We don't have platelets. Platelets stick. They form blood clots. The symptoms would be then that person bleeds very easily. Right. Other things that might occur, the petechiae, which we've mentioned before, and we saw a picture of purpura, but we didn't see a menorrhagia would be excessive amount of menses, right? Epistasis again would be the bleeding of the nosebleeds, the spontaneous nosebleeds that continue on and don't stop, and then bleeding of the gums. You know, I've also bolded that one. So as we end this slide, specifically this lecture, some of you might know what this is, but this is up in Provo, and this the Y as you do the Y. And so oftentimes when we're talking specifically about clinical significance or specifically statistical significance, we use the p-value of 0.05. So I always laugh at this sign when we walk by it, and especially after we finish a long day of biostatistics. So that's my form of humor there.